Good morning, everybody. So after a very wonderful session from Dr. Bhaskar Shinoy, we'll move to another day-to-day syndrome. I think again it's a syndromic approach, as rightly mentioned by Dr. Bhaskar in the first session. And for the next 40 minutes, I will try to cover 3 or 4 cases about fever, hepatosplenomegaly, and lymphadenopathy. So good morning to everybody. So I will not be going in detail what is hepatomegaly, what is splenomegaly, what is lymphadenopathy. We'll straight to go with the cases. So here I have a case. Can I pointer please? Here's a 2-year-old child. Weight is 8.4 kg. Height is yeah. So can it be little? Or you can come forward. Yeah? They will come forward. Don't worry, please. Yeah. So here a 2-year-old boy who is weight 8.4 kg with a height of 82 centimeter, vaccinated at the urban health center, and there is relatively a long history. A fever 3 weeks on and off. And to start with, it is a high grade fever with chills, uh, responding to paracetamol, and the child was admitted before 18 days for the fever and loose motion with a diagnosis of acute gastroenteritis with some dehydration, and discharged on day 4. And if you look at the count during their hospitalization, he is anemic, that is hemoglobin is 8.9. Total count is 9,000 with a poly of 62, lymphocyte 35, and platelet 1.65 lakh. He was better for 5 days. And again, he started to have a high fever, again, same, continuous for more 7 days. And during the second phase of the illness, child is not eating well, is not playing well, and somewhat irritable. So, anyone can take this if you want, or I can go further ahead. Yes, Dr. Sonalban.
So child is sick, having fever since almost last 3 weeks off and on, with a past history of AG, and child is also having some other symptoms in form of not eating well and not playing well. So we can say that something chronic infection is going on in the child. So my possibilities is maybe some chronic infection or inflammatory disorders, or it may be some form of malignancy. So when fever persists for more than 3 weeks, these are the 3 common group of disorders.
So it has a varied spectrum of diagnosis.
So and chronic infection in form of tuberculosis or improperly treated or hidden some occult infection.
But can it be some complication of a acute illness? Can it be some prolonged or unusual course of some common infection?
Yeah, it may be some untreated, improperly treated enteric fever also may be there, or maybe some other chronic infection which has not been picked up on routine investigation like brucellosis or something like that we have to think of.
Yeah, I like to add to man. This is a child with a sudden onset of high-grade fever with chills. Probably I'll focus on something like UTA, which was undertreated UTA, or could be an enteric fever because there is an eosinopenia, and also child did not receive, probably child didn't receive typhoid vaccine, and probably this looks like a biphasic illness. Probably I would like to add some more other elements as we go through the next slides.
Okay. So child was having a febrile with a tachycardia, SpO2 98 per minute. There is pallor is there, and there is abdominal distension, but no ascites. Liver is 6 centimeter firm in consistency. Spleen is 8 centimeter, and there are few cervical lymph nodes, bilateral, in posterior triangle, form non-tender, non-mated, and there is no meningeal signs.
Here there is a history of recurrent fever. One is 3 weeks duration, another acute onset fever. So now it is clear there is a pylori is there, huge hepatosplenohepatomegaly, and cervical lymph node.
Yeah.
So
So what are the possibilities? You can narrow down the.
yeah, I don't know whether it is from malaria endemic area. Possibility you have to always think about malaria, but lymph node enlargement is very unlikely in the case of malaria. Leishmaniasis also because there's pylori is there. The chronic infection because 3 infection, tuberculosis, typhoid fever, infection mononucleosis. You want to get a large spleen. Here it is a large spleen. Large spleen is taken to diagnosis of all this condition. Rarely may get, but those typhoid, that's a common infection. But possibility for this one is with a large spleen is very unlikely.
Can it be some hematologic disorder and a
Another thing is that 2 other possibilities, collagen vascular disease and the malignancy. So these are 2 possibilities that we have to consider.
from Ahmedabad, urban slum, Baipura, Maninagar. Very crowded and poor community. Yeah.
So I think by this presentation or examination, your enteric becomes absolutely out.
Yeah.
Typhoid fever, you won't have so big liver and spleen. And even infectious mononucleosis, not such a big liver and spleen. I think you go towards the possibility of something like Kala Azar, which is not a endemic area for your city. And they are not sick-looking children, Kala Azar. They keep walking to your clinic, and they are quite happy, okay children. They are not very sick-looking children. So with this, and as Dr. Keshwan said, cervical lymph nodes, malaria is out.
Yeah.
So I'll put it as some malignancy may be there in these cases.
Yeah.
So I like to ask a question. Did the child have night sweats?
No. No night sweat, no bony pains.
Do they have any cow or any in the family? Does the child consume raw milk?
Not that history given. So the stable I said IVF was started and ceftriaxone was started. And if you look at the counts, it is 8.9, 8,000, platelet 1.5 lakhs, CRP 38, SGPT and SGPT raised, urinism normal, Mentrux negative, and blood culture sent. XHS is normal. USD hepatosplenomegaly, mesenteric lymph node, largest being 15 millimeter. Diagnosis consistent with typhoid fever, and clinical correlation is advised. So again, we know that enteric fever is a culture diagnosis, and it's not an imaging diagnosis. So most of the time, we will not be misled by this. And our expert already says that almost malaria is out because there is no lymphadenopathy. Enteric fever is out. So we will think beyond malaria, enteric fever, and infectious mononucleus less likely.
The ultrasonologists stick their neck out and say enteric like.
Sir,
And cut a sorry figure later on.
Because
these are usual words they type at least in Ahmedabad. I don't know about Delhi. So, if you look at the further course, fever is still persistent, not responding to routine manage, and there is now a new onset of arthropathy. There is a pain around right knee. Now child looks more irritable. There is marked irritability. However, there is no meningeal signs, no rash, and clinical exam is almost same. So, Dr. Kukraja, what would you now do?
Now this is a child who has got massive hepatosplenomegaly. There's a knee joint involvement. We do not know what exactly it is. And the patient looks ill. All these things and indicates we are having some systemic pathology. And it could be infections like brucella and tuberculosis, which come to my mind seeing this presentation. And but again, I think your lymphoma can present like this.
Yeah.
Lymphoma can present like this. Leukemia with the normal platelets, not very
Slightly low, 1.5.
but I think lymphoma can fit in, and 2 other infections like brucella and this thing. Brucella, most common is sacroiliac joint, then is a hip joint, then is a knee joint. So it can happen in brucella. And is there a history of having raw milk and all?
Not
cheese and all
there.
that?
Not there.
So I'll put it more towards number one.
But
lymphoma.
nowadays, raw milk is required for the diagnosis of brucella
It's not-
because we
it's
are
not
using
required.
so many milk products and we don't know the source of that.
It's not required. I had a discussion with Bikaner people. They say
Yeah, Dr.
the
Khatri,
cheese is made
Cheese,
normally
yeah,
from
yeah.
raw milk.
raw milk, yeah.
So that's a big problem.
Even we go for the Sampu cocoa and coffee,
milkshakes
they
and
give raw milk.
So not a history.
Milkshakes and all
Yeah,
they
yeah. So
consume
it's now-
outside, they also.
So now only one point that if you have brucella, can the child be this toxic or
No,
this
no.
sick? So again, see, yeah. So
Brucella
brucella
children are not
usually
sick.
there is no bacteremia. Usually there is no.
Usually brucella children again come
Yeah,
walking
exactly.
and limping.
And how about lepto, sir? In this case, lepto.
Too long age.
Lepto one unlikely, sir. And here, what about a new joint pain? If it is a joint properly, it may infection. If it is a periostitis, it may be infiltration due to some malignancy.
So because of this arthropathy, we did a PCR dengue CT is negative, CPK 108, LDH 278, ferritin 189.7, D-diamine 588, brucella IgM is negative, VCA IgM for EBV normal, HIV non-reactive. And would you like to go for TB workup, sir? Anyone? TB workup?
Yeah, definitely we
Yeah.
should go for.
So we did
TB
also that,
workup.
two annual and echo was also normal. So to summarize,
XHS.
what is the normal, sir?
XHS.
No, normal. There was no hyaluronic.
Do you still do Manto, sir?
Mentos were negative. I'm coming to that.
Are
Yeah.
you still
So
doing
to s-
Manto?
Huh?
Are you still doing Manto, sir?
Yeah, we
Yeah,
do
we will
Manto.
do it.
We
We
do
do it.
Manto.
It's a non-specific. One in presence of clinical diagnosis will increase its specificity to some extent. So it's not a throwaway test. It will not be available. That's why. But it is. We definitely do it. Two to you. So to summarize, the illness of 20 days, and the last episode is febrile 7 days. There is hepatosplenic lymphadenopathy. There is low hemoglobin. There is progressive thrombocytopenia, not that severe. Elevated liver enzymes. And investigations, the culture has also been found. COVID antibody negative, urine culture is normal, and blood culture is sterile till date. So almost I've given this report to you. And we did.
Just go back. I think if you have a ESR which is touching 100, if Vishwanathan is here, he'll give us 3 diagnoses. One is tuberculosis. Second is he'll give a diagnosis of malignancy, lymphoma. And third is autoimmune disease.
3D, yes, sir. Yeah. But the CRP is only 38.
More fitting towards lymphoma.
You can even have in Sogia, you can have a CRP that's low and a ESR that's high.
But in Sogia, there will be thrombocytosis.
Usually there is.
There is leukocytosis.
Not always.
About
Unless
Leishman-
it is complicated mass or something, most of that is a thrombocytosis.
So, yes, sir. That's the hepatosplenomegaly.
And you look at the ferritin, only in the 200, 300, there is marked hyperferritemia as well as this Sogia is concerned.
Leishmania still a possibility.
So we did the lymph node biopsy and stand it for the Jaren state for AFB. Lymph node biopsy, there is reactive hyperplasia. So no granuloma or caseous necrosis. So Dr. Kukre, there is no lymphoma as well.
So
So-
again, brucellosis, we have to consider because it can present with.
But would you not
very
like to
kind-
go for the bone marrow biopsy, something like that?
Lymph node biopsy can do. Bone marrow.
But brucella is not same. eh?
It is negative. Serology is negative. We are awaiting for the blood
Okay,
culture.
but sometimes
This coming. Yeah. I've done it. On the third day, it is negative. Yeah. So we repeated the CBC again. There is drop from 8.9 to 8.5 gram. Platelet have from 1.5 to 1.88. ESR 90. CRP 52.7. SGPT 240. So almost we rule out malaria, enteric, EBV, brucella, seronegative, TB almost not there. We have thought of non-infectious conditions. So all other possibly have influence. So but
negative serology may not rule.
yeah. So we
So
did
we
a
need to go for the either culture or PCR or something like that.
yeah. So we did also CT, and we saw that there is a hepatosplenomegaly with multiple small, poorly enhancing hypodense lesions, multiple glands in the sub-centimeter size in precaval, para-aortic and mesenteric areas, and the possible lymphoma more likely over granulomatous lesion of infective artery, bone marrow advice. So naturally we'll go for the bone marrow, right? In this case, And on the day of bone marrow, again we did the CBC. The hemoglobin is 7.6, total count 12,800, platelets still low, 98,000, and ESR 67, immature retic fraction 30.8. So bone marrow also does not show any leukemia, lymphoma. So what do you want to know? Bone marrow biopsy. Same. We have not shown the culture. That is the biggest mistake that I have done. I have not sent the bone marrow culture. I should have sent it for the bone marrow culture, but yeah, so it's a message that whenever you're doing a bone marrow for any reason, send it for the culture, which I have not done this is. But I was lucky to find something else in the blood. So there is a hypercellular marrow, adequate erythropoiesis, hyperplasia, and adequate megakaryocyte. But the blood culture, what was Dr. Kure said, the prolonged incubation, it turned out to be a Brucella mediensis. So it's a case of Brucella. So my Dr. Sonalben, you were telling me, so what are the pros and cons of all the Brucella diagnostic modalities?
Yeah.
And would you go for the empiric anti-Brucella treatment in such case?
Yeah, so like if you have a strong possibility, like definitely clinical features suggest you of pyrexia for a prolonged period with hepatosplenomegaly, with lymphadenopathy, with epidemiological background like history of consuming raw milk or surrounded by the animals or something like that, such history is there. We should always send for serology. If serology is negative and still we have a doubt about this, we can send about
So what are the
culture.
chances that a child has a false negative Brucella serology? And what is that process is described as?
Negative serology can be there almost in like 20 to 30% of the patients. It can be negative in spite of being it positive.
So in your college,
So-
which test would you do? Rose
Yeah,
Bengal?
we advise
Or
PCR or culture.
Acha, PCR.
Or culture.
Dr. Kukre?
I think Bikaner people, some centers are doing there, but our center, then we do a long blood culture. And, many times,
And we sometimes give even therapeutic trial also, because usually they respond very well to doxycycline and rifampicin after 5 days.
Microcephaly, yeah.
So these are three ways.
So she told about empiric one minute, one sir. She told about empiric. I think for Brucella I would
Strong
not give.
possibility.
Had it been a rickettsial case, I would have given because doxy is life saving. But the Brucella, we expose the child to doxycycline, rifampicin, so many drugs. So I think to give a blanket statement that when we clinically suspect, we give the empirical anti-Brucella treatment. I think it's a tall order for me at least.
I like to add, preferably you should not do with a single serology. For Brucella, if you do for single serology, sensitivity and specificity.
So these are
is very
3
poor.
weeks of the illness, and why to go for the second sample?
After 4, you need to have at least 2 titers, 4-fold rise, or you need to do SAT and
Sir, that is
IgG.
point well taken, but the child is already come after the illness of 3 weeks.
Did
So
you do
there might have been the reason tighter.
at the first itself, you would have done Rose Bengal test, screening test.
Okay.
Have you done Rose Bengal?
Yeah,
sir?
if culture
No, we
or
have to go for the
PCR is
ELISA
not
agent.
freely
ELISA.
available, I do send serial
Yeah.
Brucella because
So
right
sometimes
now-
what happens is Brucella, when you use the serum agglutination test, there are abundant of the antibody. Out of them, if the non-agglutinating antibody is more compared to the agglutinating antibody, your Brucella serology may be a false negative, which is described as Prozone phenomena. So it's very classical in syphilis and in Brucella. So we end up here with the first case. Another child, a 10-year boy. Here is a short febrile illness of 8 days, mild to moderate, intermediate nature for the initial 3 days. On day 4, the fever spikes are very high grade. Response to paracetamol is not that satisfactory. And child also started having generalized macular rash, starting from the trunk, progressing to all over body for next 5 days. There is also an edema. So there is a fever, there is rash, there is edema all over the body, and there is periorbital puffiness, which gradually progress to involve the whole body. And child is sick enough that is the oral intake has reduced. And before 5 weeks, there is a short febrile illness of high fever, loose motion with blood in stool, abdominal pain, pain in both knee joints, and some backache. And for that child was received ibuprofen, two analgesics, that is ibuprofen and naproxen, and two antibiotics, that is ofloxacin and metronidazole. So that is the history. So there is a fever, there is rash, there is edema, and the child is sick looking, febrile. SpO2 at room temperature is 91 and with minimal oxygen is 100%. There is generalized erythematous, somewhat itchy maculopapular rash, edema all over the body with a preponderance in the periorbital area. Again, there is a cervical lymph node on both the sides, which are multiple, non-tender, discrete, soft to form in consistency, 2 by 3 centimeter, largest in the submandibular area. Few scattered lymph node in the left axillary area. There is no pallor, no icterus, no bony pains. Eye, throat, lips is normal. So two groups of lymph nodes are involved. So we have got the fever, we have the rash, we have the edema, and we have got the lymph node. And the child is lethargic but arousable. There are no meningeal signs. Air antibile normal. CVS prominent but third sound, no murmur. There is edema over the abdominal wall. Liver 4 centimeter below costal margin with a span of 10 centimeter. Formin consistency non-tender, and spleen is not over. So there is hepatomegaly as well. So anyone can take this, sir. I want to go back, sir, with the history. Anyone, sir? Yeah. Please just start.
Child here, in the initial, till we are knowing the past history, child got a fever, then after 3 days, child got a rash. So it is very unlikely to be routine condition like measles or rubella like that, because rash appeared after 3 days, something like that. So there's no question like that. Then here there is question of jaundice, rash, so and irritability also. At this point we are thinking about Kawasaki disease, something like that, because child got
Even
irritable.
age is not favoring.
But age is not favoring. That is another this one. Then we are thinking about the past history. Past history, we got some joint pain, abdominal pain, and blood in the stool. So we are thinking about some immunological reaction in connection with that one in the form of summer.
Yes.
I think
Yes, sir. Please.
this is, if I relate this with the illness which has come next after 5 weeks, so it is a multi-system involved. So what is happening? The patient has got fever, patient has got rash, patient has got hepatomegaly, patient has got knee hit or maybe some edema because of other reasons. So there are multiple systems involved. So
And lymph node. And
lymph
lymph node.
and lymph node. All these things indicate that I'm dealing with a multi-system involvement, and because of maybe this illness, and if it's because of that, it is some autoimmunity because of related to that. This is one thing coming. I need more information to make up my mind what I'm exactly dealing with.
Sonal, do you want to add something?
Yeah, because history is very short right now at present. Fever is of almost 8 days. So it will be little difficult too early to think of autoimmune disorder right at this place, because then,
So can be a acute on chronic?
but there is
There is no
maybe
issue.
past history before 5
No,
weeks. there
child
was
might be sick and some lymph node may be sitting before since 2 months.
It may be there,
Maybe one of the
but
organisms.
we would
I
like
think
to know the
with the
progress.
past history, bloody stools and the joint involvement, probably I'm thinking of Campylobacter jejuni, but it doesn't extend to this level.
Yeah, Campylobacter cannot go so long. So this is a rash. Of course, this is during the convalescent phase, but you can see some discoloration also is there. So now anyone can take this. A pretty sick child, fever, rash of short illness, lymphadenopathy, hepatomegaly, edema. What are the likely possibilities?
Maybe some kind of infection like rickettsia, because there is fever, rash, lymphadenopathy, edema, and hepatomegaly. The classical
But in
of,
Gujarat, we don't have that.
rickettsia.
That's
No,
all.
it's not like that, because we
But
may be
still we can have it because
underdiagnosing.
of this.
Yeah, we can have this.
So,
Because if
so
you have a
patient is pretty sick. So with this rash,
yeah,
edema,
it can be there. Even rickettsia can present as
no only rickets. Then what else?
meningitis.
What else? What else?
Multi-system inflammatory disease we have to think about.
Yeah.
Miss.
Periorbital edema can be seen in case of typhus.
Yeah.
It can be seen. Things like can
Yes,
be
but-
seen in intestine.
What about
But
dengue?
rashes are not that
What about
common
dengue
really.
shock? Dengue shock?
Dengue
In this case, it is
shock,
unlikely, but
dengue
can
shock, lymphadenopathy.
not. Yeah, so it is against this. Yeah.
So it could be out of these. I think
Yeah.
some sickness I won't put it because
Yeah.
joint involvement is very
Yeah.
common.
So dengue can it be septic shock, sir? Septic shock.
No, it cannot
cannot be.
because, yeah.
And what about toxic shock syndrome?
So,
Miss-
because again,
Miss C?
lymphadenopathy and
Miss C?
Can be thought of.
Yeah.
Past
So
it's,
you are seeing currently this patient.
So when a child has got a fever,
When does
rash,
this patient see?
huh?
When this patient? But which months? This
In the
year-
in rainy season, during
this
rainy.
year only?
Yes, yes,
During
yes, yes.
COVID
So
time
it is
or
not. It's not missing. Don't
It
worry.
is.
Not Miss C, yeah. Yeah.
epidemiology is not important.
cannot be
yeah.
meningococcemia
And it can-
also.
possibility of looking at the rash, it
Scrub
looks like you
typhoid.
can include Steven Johnson, you can take it to the top.
No, these are all the causes with the fever, rash, and unstable vitals. So it can be anything. In this, I think the dengue is unlikely, septic shock is unlikely, TSS, MIS-C. So what possibly remains the scrub typhus, or it can be a KD, or it can be Stevens Johnson by any drug rash, right? Yeah.
Yeah.
So now how to proceed? We have to take a, so would you start antibiotic, Dr. Praj, in this case? We have already started vancomycin, ceftriaxone, clindamycin. Would you start antibiotic or not? That is what we have done.
Don't have a clinical diagnosis. If you don't have a clinical diagnosis, it's just giving a wide spectrum and just to wait for the report.
But it's a, you may have narrow spectrum, little.
No, but we can't
See, but
straight
if
away
I'm-
start with all three drugs together. without
But I was very sick, very sick.
Yeah, but
And also
still,
3 antibiotics
It
not
is.
in.
but in-
No, it's not like that. There is,
I feel
that
just
is
go
why there
back.
is a
Just go-
science behind it.
See, what
Patient
is
is in
good-
shock.
I think what
So
is
gram positive, gram negative, and toxin, all three have been covered. So I have left meropenem.
toxin.
Edema, sir, edema is there. There are lot. Edema is there.
edema is
Edema,
not,
hepit,
not
Edema
indicated.
you are related with capillary leak.
yes. Any toxin related illness, any vasculitis can have any edema.
But still, all three antibiotics at
No,
the
madam.
time without the
Then what would you have given? That's why I'm asking. That answer I don't get from any of the experts.
we could have like sent few more investigation.
No.
Then decide.
Patient is
Maybe
unstable.
at least only just ceftriaxone
Urine
or
output-
something like
Okay.
that.
Not all uric.
And there's no kidney functions are okay.
Okay. I'm coming to that. Yeah. Okay. Yeah. So these are the reports. Hemoglobin 18. Total count is little high, 18,000. Poly 63, lympho 32, eosinophil 5%, platelet 1.98, ESR 24, CRP 32, SGPT, SGOT 240 and 170 respectively, PTINR 1.1, serum albumin 3, blood urea 48, creatinine 0.8, urine examination normal, and sodium is 139. Blood culture.
Abhay, I think seriously think of dressing.
Hmm?
Seriously, you should think of dressing.
Okay. So
Blood urea.
eosinophil is 5%. Yeah. And so if you look at the absolute, yeah, count is also there. Exactly. Yeah. So you have a eagle eye, sir. The blood culture is awaited, NS1 negative, serology negative, HIV IgM negative, COVID antibody negative, X-ray prominent via both sides, and sonography of abdomen revealed mild hepatomegaly, normal echo structure with minimal of the ascites. So why this dress syndrome, sir?
There's a drugs given 5 weeks ago. There's a rash is there, fever is there, lymphadenopathy is there, and multi-system involvement is there. What
Yeah.
else you need to make a
Exactly.
Uh,
You
and
have hit the
also,
nail. So
yeah,
I will not
you-
go in the further progress. The fever spike increasing, edema increased.
Only thing is, I think generalized edema. That's the only thing
Yeah.
against. But sometimes it may lead to capillary
In
leak.
dress syndrome,
But,
you have
sir,
face
only-
edema
only-
first, and the rashes start in the face first. Whereas in Steven Johnson, the rashes start
Yeah.
in the trunk. That's the only thing that is.
Now, sir, when we did the further follow-up, child was having high spiky fever. You can see that eosinophil is 14%. So again, it yes, it is that. But you need the procal. It is 2.4. So how will take this?
No callus used us many times.
Okay.
Okay,
Yeah.
no cal can be.
Yeah. So DRAS is a diagnosis by exclusion, sir. DRAS is a diagnosis except CBC. What?
See, I think you have to relate everything. And you give a warning in red also.
Yeah. So
I
we deal
think
also all the
the child
serology which are
classifies-
negative, it will scrub, dengue, ferritin 389, D dimer 650 because of edema, the ecovas which were normal, and liver lymph node biopsy we also done because the child was again it turned out to be negative. There is a recursive hyperplasia with preserved nodal architecture, and there was mixed cellular infiltrate of small lymphocyte, eosinophil, histiocyte, and finding are suggestive inflammatory disorder rather than infective etiology. And what sir is saying that there is a history of drug exposure, there is fever, there is rash, lymph node, two organs affected, hepatitis, eosinophilia, the sepsis and shock-like presentation. So it's a Regis-Kerr criteria about Rett syndrome, and almost 3 out of 5 is required. This patient has nearly 4 criteria. So it turned out to be a case of Rett syndrome. We started with the steroid and child responded well. So our expert has hit the nail exactly. So the third case, a 10-year-old boy, previously healthy, fever for 10 days, high grade, often associated with chills, occurring mostly at nights, and relieved with oral paracetamol. There is history of loose motion, 6 days, 7 to 8 per day, without blood or mucus. Abdominal pain for 4 to 5 days, localized periumbilical, without any specific exacerbating or the relieving factors or radiation. Vomiting for the last 3 days, treated outside by family physician with IV fluid, some injection. Past history, personal history, family history, nothing special. So I think, can you quickly one or two difference diagnosis with this history?
Since the child has fever since almost 10 days, so like we have to think of cause and associated with loose motion. So any infection, like any viral infection can be there, which is prolonged somewhat. And
10
even
days
enteric
fever,
fever
viral,
also you can think
high
of.
grade fever, 10 days.
Yeah, so
By
less
day
likely,
4 or
but
5, viral would have been
yeah,
either
so enteric
complicated or
fever,
would have recovered
of course, is
completely.
a first possibility we have to think of and investigate further for that.
How about
And so
pancreatitis, madam?
pancreatitis usually, it can be there, yeah, but we need investigate further. We would like to
So
further.
again, it's a varied, this again, enteric fever, gastroenteritis, viral, pancreatitis, dengue, any can occur. So we investigate carefully. And the child was conscious oriented. I will not go much detail, but the liver was 3 centimeter, spleen 2 centimeter. Rest of the system is normal. There is no pallor, no icterus, no clubbing, and vitally child is stable. So now, Dr. Anand,
Yeah.
which university would you go do
Yeah,
in this case?
madam rightly mentioned because started with the GT symptom. Now mild is splenomegaly. Liver 2-3 centimeter, spleen again 2 centimeter. So we have to first keep the possibility of enteric fever.
Yeah. So here is the CBC, the 10, chloro count is 600, platelet normal. Again, second is also hemoglobin 9.6, CRP is 121, SGPT 51, 80, SGOT 89, electrolytes normal and blood culture awaited. Mammalian antigen test negative, NS1 serology, serum amylase and lipase were also within normal limit. And there is the US hepatosplenomegaly.
The TCDC is showing low eosinophilia.
Then-
Eosinophil count is 1 and 0.
How does it matter, sir? There is
That is
eosinophil 1 and then eosinophil 0.
there is some documentation like that. Maybe it is.
So, Dr. Kukreja, what is the take on eosinophil enteric fever?
Normally see eosinopenia in cases of enteric fever, and I think one of our fellow has done study on that, and eosinopenia is quite a common phenomenon.
But its absence will not rule out.
And I think
enteric fever.
in these counts, the only unusual thing against enteric is normally they have a relative neutrophilia compared to lymphocytes. That's the only
Yeah.
unusual thing. Otherwise, CRP of high, SGPT increased, all
Yeah.
these things are seen in enteric fever.
Yeah.
And clinically, it fits into enteric
Yeah.
fever.
So we did also the blood culture. It's positive and sensitive to ceftriaxone. Now we have started ceftriaxone in a perfect dose, and there is no thrombophlebitis thing. So Dr. Neminathan, there is no response on day 6 against spiking fever. Another child is deteriorating. So what
Yeah.
are the possibilities?
Probably there is some complication related to sunlight infection. I would I probably like to add on another drug like azithromycin, or I would like to think of because considering resistant organism, or like to think of something like HLH following salmonella typhi.
Yeah. Dr. Sonal.
Usually Salmonella typhi
No,
enteric fever.
ceftriaxone
Yeah,
on day 6, what would you
It usually
expect? As,
responds, our 99% patients ceftriaxone sensitivity is there. So again, we can add azithromycin and as well as investigate further for some immunological complications of enteric fever like secondary HLH, and we would like to repeat the CBC and see for the diagnosis like whether the other series called or
so
not.
Dr. Kukreja, you
leukopenia.
will add the drug
No,
or change the drug?
I don't add it.
Yeah, exactly.
Absolutely. And whenever there's a patient not improving, I think there should be effort made to investigate what is happening to this patient,
Yeah.
why this patient is not improving. And number one, I'll look at the MICs. The MICs in my center are okay to ceftriaxone.
Yeah,
I'm
okay with
quite
that.
happy.
Yeah.
And we hardly have any resistance to ceftriaxone as being reported from Baroda.
Yeah.
But I think you are getting a clinical response, even if there is a
We are getting it,
so,
sir.
even if I think, for example, in many cases, if you have a resistance, it is responding to ceftriaxone. But in our lab, there's hardly any this thing.
So
If
message
the
is-
patient is not improving, I will look for any complications.
Exactly.
If there's other things going on with the
So child still becomes sicker. There is mild tachycardia. Some rash is developing. Hepatosplenomegaly has increased. The distension is there. You can see the count. The hemoglobin is falling. The platelet is falling. CRP is rising. And you can see that ESR, which was previously 80, now 48 and 23. So what is happening to this?
So, any hemoglobin is also falling, total count is also decreasing, and platelets are also decreasing. So it always favors some immunological complications. So
So,
we must
But
investigate.
why
for-
child is such sick and ESR is falling?
No, because it is a immunological, HLH is maybe developing. So in that condition, you have bone marrow involvement.
But organomegaly further increased.
It has increased markedly.
See, in HLH, ESR and your CRP, they move in different directions. ESR goes down and your CRP.
So-
Normally, this is what happens.
So both are in opposite, paradoxical. CRP is rising, ESR is falling, child is worsening. So there is hypofibrinogenemia. And because of the low fibrinogen, the ESR is falling. So in a otherwise unwell child, a falling ESR is a sign of ill omen. So I think
Did you do triglycerides and ferritin, sir?
Huh?
Triglycerides and ferritin.
I'm coming to that, yeah.
Yeah.
So we did all the viral markers negative. So we have also started meropenem, and you can see that ferritin is 5,000, triglyceride is 563, and we did. So now anyone can take. We see a lot of infection, and post-COVID we usually do when the illness persists for more than 4 or 5 days. We do ferritin left and right. So what your take? It is infection, it is non-infection, or it is always HLH?
We are getting a lot of cases of HLH due to so many infections. Typhoid, dengue fever, all this we are getting very common HLH we are getting.
Okay. Sir,
If there is a unexpected response, for example, in this patient, you are expecting a response with ceftriaxone, and child is suddenly becoming sick, and there's a bicytopenia, and ESR is falling, it's very, very suggestive that this patient has got into HLH. In that situation,
No,
in
sometimes
our
we see-
center,
sometimes with
immediately
thousands
we
of
send
ferritin and there
TG,
is not-
immediately we send TG and ferritin, and if these two are high, we are very suggestive that we are dealing with
no, but
HLH.
sometimes only ferritin is high, aspirin dengue. Sometimes I suspect it is sogia. Ferritin is very high.
So I do you to relate with clinical condition. Na?
Yeah.
It's very important to relate with clinical condition.
So bone marrow also suggestive of the HLH, and these are the criteria for the HLH. Fever more than 38.5, splenomegaly, bilateral peripheral blood bicytopenia, hypertriglyceridemia which was there, hemophagocytic in bone marrow, and ferritin which is more than 5. So I think 5 of 8 criteria should be there, and this child was a case of HLH following enteric fever. We started with IV dexamethasone, and we can discharge hemoglobin 10.2 and platelet was 98,000. Now it's 2.33x. So it's a case of enteric fever complicated by HLH. So this is the third case. We finish it. Only one sentence each of from you: fever, hypersomnia, lymphadenopathy. Can I have a control? I have fourth place, but I think I will honor the time.
Yeah.
Good.
So
Take home message from you.
Any common like infection like enteric fever and dengue, something like that, if they follow the unusual course, like if in this case if the ceftriaxone, because ceftriaxone sensitivities resistance is unknown, so if patient fails to respond to culture positive salmonella typhi and persistent continues to have the fever, and along with it if there is a hepatomegaly and bone marrow involvement, so we must look for the immunological complication in time and investigate accordingly and treat accordingly.
I mean,
Yeah, to the youngsters, all fevers are not infectious, and all infections are not bacterial, and antibiotics is not antipyretic.
In a case like first case, huge hepatosplenomegaly, you have to think about the rare conditions. And even though culture is native, then you have to do extended culture and some other important investigation. So rarely think about rare condition like brucellosis. Brucellosis also you have to consider.
What I practice in my this thing is I tell my all fellows and my consultants, whenever you have a patient coming to the emergency room or the OPD, in a case of infection, if you take a good blood sample per culture, I think lot of your problems are solved. And take a adequate amount and take a paired culture. And if you don't do that, then you are hitting the bush, not knowing what you are doing.
yeah.
So it's very, very important that at the onset, have a good culture, paired culture, and so that a lot of problems can be solved.
So thank you all the panelists, expert opinion. Thank you everybody.
Thank you, Abhay sir, and all the panelists for wonderful session.